Okay, so it's 1 o'clock, so I think we'll get going. It's a pleasure to introduce our very first Metalwork session. We've got 2 great speakers to start off. We have Dimi Amiras and we have Warren McDonald. Thanks, Dimi, for starting. And can you unmute yourself?
I did that on purpose, so everyone felt comfortable about that going wrong for them, as we've all got used to in COVID times. Okay, so I'm just going to share my screen. Please don't be polite if there's something that's not working, or just unmute yourselves and just let me know. So I'm Dimitri Amaras. I'm one of the musculoskeletal radiologists at Imperial, and this whole course is all Marcella's fault. So we were coming back from a BSSR conference, and we were both expressing how inadequate we felt about reporting plain films after orthopedic metalwork had been done, even though we both done fellowships. And we thought it'd be really good to do a course that would help talk about that, connect orthopedic surgeons and radiologists, so we could form a really good report. We could understand what was going on, and also we really wanted to try and understand what how everyone else felt about it. So this is the first of a series of lectures. We've invited radiologists and orthopedic surgeons to come and talk and give their opinions about what's going on. It's meant to be interactive, so there will be bits where you can interact. I've used PolyV to do the interaction, and I've got to say a big thank you to Elizabeth for allowing her to use for us to use her Zoom account and also her PolyV account. But if it doesn't work, I apologize. This is what I'm calling a lean teaching series. So we're trying to do it with the least amount of cost and try and get the maximum benefit out of it. If it's not smooth, I totally apologize. We would love to get your feedback, so you can either do that in the chat, or if you email us at orthopedicmetalwork@gmail.com and let us know if there's stuff in the course that you'd like to hear more about. Let us know. We can try and get some more speakers and potentially have some other sessions on there. Elizabeth has gone through the house rules, but I just remind you, if you can mute unless you've got something to say, if you could raise the questions by the chat, that would be great. And it will be recorded. And for those of you who haven't got it already, the PolyV account is Elizabeth087. So, just to get everyone warmed up, I'd like you all to log into the PolyV account. So it's polyv.com/ElizabethDick087. And if you could share with me any activities that you enjoyed during lockdown. Eating, yes. I think we're all guilty of a bit of eating. Swimming, cool. I think a lot of people living on the coast there, I'm very jealous of. Yoga, excellent. Very important to be centered during this time. And yeah, sleeping. Everyone is definitely guilty of some Netflix over this period. There's lots more of you signed in, so I'm just going to wait a little bit longer so that you all get onto the PolyV account. Yes, there is a lot of health-related activities here: swimming, yoga, running. I'd like a few more guilty pleasures if that's possible.
I don't honestly think this is representative of what many of us did in lockdown, for sure.
I hope not.
It's definitely what we will admit to.
Yeah. Getting bored. Wow. I think it was a tough time, wasn't it? It's amazing how much you realise work provides you with stuff to keep you occupied. Drinking wine, whoever said that gets full marks and can have certificates for the rest of the course.
Sorry? I don't know.
Just to remind everyone, if you could mute yourselves, please, that would be great.
Okay, so while there'll be, I'll have links for the PolyV account as we go through the talk, but we'll move on to the next bit. If I can. So, first question is about MRI. So why would you use MRI for postoperative orthopedic imaging?
Again, I think there are a couple of people who aren't muted yet. Would you mind all muting yourself? Thanks.
Yeah, infection and fracture, loosening, metallosis. Okay, there's some centers that want to do a baseline study post-op. Now, I think that's probably a bit unusual, but yeah, I think complications in general and recurrent disease. So I think the reason that this is such a difficult question is that we don't really have good guidelines about which imaging modality to use when we think there are complications post-operatively. And the reason is that actually most of the time with a good history, some simple plain radiographs, you can actually diagnose most of the problems. A good orthopedic surgeon can take a good history and listen to the patient, and with the combination plain radiograph can come up with most of the answers. MRI is used for when the orthopedic surgeon needs to make a decision about an operative decision or not, or there is concern about how we continue the treatment. So let's just talk a little bit about MRI. So this actual picture of the wheelchair was taken at Imperial, and as you can see, there is definitely a very strong magnetic force, as I hope you all know, in MRI. Now, why is that important when it comes to imaging metalwork? So the problem with that is that the mains field that you can see there, which is drawn by the arrow, the B0 field of the magnet, is affected by any ferromagnetic substances in there. And we need that field to help us locate the signal that we're picking up from whatever MRI sequence that we're doing. So any ferromagnetic object there will affect that field. And unfortunately, that's what causes most of the artifacts associated with metalwork. Now, there are several ways that we can overcome that. This is an example of, from 2010, a radiographics paper. And on the left-hand side of the screen, you can see an MRI of a hip replacement with lots of areas of increased signal and reduced signal. And this is all to do with the inability to identify where that signal is coming from, just because of the change in the B0 in the magnet. And just by using some simple techniques, you can actually greatly reduce the distortion that you get with metal artifact. So the main simple techniques you can do on almost any scanner is increase the bandwidth, increase the field of view, narrow your slice thickness. Now, there are some other features you can do, like do your view angle tilting, and there are some other new sequences that come out. These do tend to take a bit longer, and then you start to get movement artifact in the same space. Also, avoid gradient echo sequences and avoid using fat suppression, because they can also cause similar artifacts. This is an example of a CMAC combined with Maverick from the GE scanners. Now, a lot of your modern scanners will have these built in. We only have one scanner with a decent metal artifact. These are all a form of view angle tilting and trying to account for that frequency encoding that you have done. If you haven't got these sequences on your scanner, you still just go back to your base principles and increase your bandwidth, field of view, and try not to use your gradient echo sequences and stick to stir rather than fat suppression. And actually, you can still get some pretty good images that don't take as long as some of these dedicated sequences. But if you have got a new scanner, then please use it. Always, when you're trying to procure a scanner, try and get these sequences put in. So this is first case. So most of my talk will be case examples. So this is a patient who's presented with hip pain after several redos and query cause. This is the plain radiograph. And this is the MRI that we've done. So the MRI on the left-hand side is an axial T2, which is using the CMAC protocol. On the right-hand side is just a high bandwidth T1. So you should be able to see those images on the PolEV account. And if you could just press on where you think the abnormalities are. Yeah, so I think a lot of people have picked up that I've helpfully put in a nice slice localizer, which helps you to identify where this is in the 3D space. And yes, we have got a collection around the, should be able to see my mouse there, but you've got a collection around the prosthesis, around the femoral stem, which is increased on the T2 and increased on the T1 images, and is likely in keeping with an infected prosthesis with some hemorrhagic change. And if we were using a normal MR sequence here, there is no way we would have seen this. It's very close to the metalwork, and is an example of when MRI has been really helpful in trying to make the diagnosis. Especially when there's been complex orthopedic work in the background. So here's another hip prosthesis. I want you to identify any abnormalities on this plain film. Again, if you could just press on the image. So this patient actually had an unexplained fever. And it looks like all of you have picked up on the cement bone interface lucency, which is really, really great. And to investigate this further, we did an MRI scan. And you can see there are extensive collections in the trochanteric bursa, and actually on the other side as well, they've also got a hip prosthesis. And this patient then went on to have a PET scan as part of the investigation for the fever. And you can see that there was increased FDG PET activity around both replacements. And this was actually multi-systemic Staph aureus infection. Just a little thing about PET. We're going to talk about SPECT-CT in a little bit, but it is useful for looking at infection around prosthetic joints, and if you look at the uptake at the bone prosthesis interface, that seems to be fairly consistent as an indicator. You can also do labeled leukocytes with PET, which can be helpful. It's important that you discuss this with your local nuclear medicine department to see what they can offer and how and what availability they have for this. Mostly, I must say, at Imperial we do SPECT-CT scans for most things. So this is another case example. So this is a prosthesis that's been in place for about 10 years and has been getting progressive pain. So I'd like you to tell me what you think the next most appropriate investigation is. So we've got 4 results so far, 5. So I'll give you another, what should we say, another 10 seconds, then we'll move over. Yeah, we've got to about 14. So let's see what everyone was saying. So most people have picked SPECT CT, and no one's actually picked the correct answer, which actually is none of the above. The most important thing is to check the preoperative radiograph. So this was 2009, and that showed that all this change here is new. So this is very concerning for infection, new bone formation. There's periosteal reaction here, and probably some erosion here. So yeah, never forget the previous imaging. It's the most powerful and cheapest form of investigation. Okay, so this is a blood pool phase of a bone scan, and this shows marked increased activity around the prosthesis. Again, confirming the presumed diagnosis of infection. And those of you who said SPECT CT can be rightly justified in thinking that was the next best test. I've already told you that was infection, so we'll skip this one. And then if you guys could give me some indication of why you would use CT for post-operative orthopedic imaging if you're worried about a complication. Yeah, so someone's mentioned alignment, which I think is really good, a really good point. Looking for metalwork failure, yeah. Looking for fractures, less artifact, yeah. So depending on the technique you use, yeah, you can get a lot less artifact. Again, alignment and fracture. So I'm really pleased to see all of those answers, and periprosthetic fractures. So we do a lot of trauma, and recently we've actually seen quite a few of iatrogenic fractures from complex trauma and fixation. So it is really important to really do look at those CTs that the orthopedic guys often just put them in and say, oh, what's the alignment like? I want to check everything, but do look and see if there's any other complications like that. So thank you for those. So this is a case that actually I've borrowed of someone called Andrew Sonin this is actually from the OCAD group, so Case a Day. And it's a 73-year-old with left hip pain and no history of previous dislocation, but no recent trauma. So there's the plain radiograph. We'll get to see it again in a second. There is another view. And then I want to see if you can point to the abnormality on the film. So we'll go through the films during the course of this course to see what you should be looking at. Okay, so I can say that you have found one of the abnormalities, but there is another one that's a really cool finding that you'll kick yourself when you look at it again. But yeah, so if you look at the stem here, it's eccentric. So again, most important thing is look at the previous imaging, and I'll show you on the next slide. If you look at the previous imaging, you can see that was bang in the center. Yeah, so that was only a year ago, and suddenly the head's moved this way. So that is the PTFE cup that dislocated out of the hip, and that's why the femoral head has moved up this way. So we'll show it to you on CT. There it is. So that's the hip dislocated, and the cup actually came out as well. Head went back in, but the cup stayed out, and that's why you know, CT is really great for all the osseous material, osseous alignment, but also don't forget your soft tissue and look at the other components of the prosthesis.
Dimi, can I interrupt to ask you?
Of course you can.
It's a very basic question. How do you know when it's a hemiarthroplasty or whether there's been a total hip replacement? You know, when you look at the plain film.
Yes. So I look at the integration with the acetabulum. I think some of our orthopedic colleagues would be probably able to identify the prosthesis just on the main appearance, but you want to see a clear sclerotic margin demonstrating if it's an articulating hemiarthroplasty. If that's what you think is going on, you need to look for a clear sclerotic margin around it, showing the joint space, as you'd expect to see on as you would on a normal hip. That's what I usually use the go-to. If there's ever, if I'm ever unsure, previous imaging, number one, and then check the notes. And then if I really don't know, I will definitely ask the orthopedic surgeon what's going on. But
and if it's a hemiarthroplasty, Elizabeth and Dimitri, the outer surface of the largest spherical site will be smooth and articulating type, whereas for a total hip, the outer surface of the cup should be textured and rough in some way. Is a kind of a first choice sign as well.
Oh, thanks, Warren. That's a really good point. This is a rare event, but can lead to metallosis, obviously, because the PTFE is out, and then you get a metal on metal effect, and they need urgent revision. Okay, so I think this is my last case. So another painful total knee replacement. To have a look at the films, and then if you could point to the most obvious abnormality. Yeah, so I think most of you are picking up the loosening around that medial aspect of the tibial prosthesis. So the next question is, what would you do next? Yes. I'd be really disappointed if someone hadn't said previous imaging. Yeah. It's just so gratifying when I know people at previous imaging. Excellent. And yeah, I think you're right. You need to talk to the orthopedic surgeon, because we often see loosening, but if the patient's asymptomatic, it's something that they can just monitor and follow up. So people are afraid to say anything else. So obviously, in this case, we didn't have any previous imaging. So what else would you do potentially? I'm going to tell you, because we did a SPECT scan, and exactly where we found the loosening, you could see increased activity. And then one important thing to check is the blood pool phase. You remember the last one, which showed infection. So what do you guys think this one shows? Okay, I think either it's not working or everyone's being shy, but yeah. So there's no uptake. So this is not infection. I think that's an important thing. If there is a concern about infection, then a bone scan is helpful to just to rule that out. And that's why it's important to work with your orthopedic colleagues to work out what the concerns is. Okay, so just in the interest of time, I'm going to move on. So we'll skip the diagnosis because I've told you it's loosening. And then I just want some of you guys to put some key points that you've learned from this lecture here. I know that some of you already learned one, which I'm really happy about. Yeah, so the role of PET. I'm just so happy that everyone's looking at the previous imaging. And if not sure, ask. Yeah, absolutely. I think that's really important. Yeah, and hybrid imaging. Good stuff. So just in the interest of time, I'm going to move on to my last slide, which is just a reminder. This is what I was doing during lockdown. I was one of those losers that got into making sourdough. And just to make the point one more time, always look at the previous imaging to see what's happened. So thank you very much for that. I hope it was useful. Hopefully some revision for some people, and hopefully you've all learned something and have not forgotten to look at the previous imaging. And I'm going to hand back to Elizabeth, who's going to introduce our next speaker. But thank you, everyone, and really appreciate you joining us today.
Fantastic. Thank you, Dimi. That was so good. And also thank you to everyone for amazing interaction and involvement. I think it really makes a difference. I'm going to introduce our next speaker, who is Dr. Warren McDonald. We don't actually have any questions for you, Dimi. If any more questions come through, everybody, please feel free to send them through the chat, and I'll interrupt Warren whenever the time comes. So Warren, I see you've just unmuted yourself. The floor is yours.
And can you hear me clearly?
Yes, thank you. That's great.
Excellent. Good. So shall I share my screen and start in?
Yes, please.
Right. So, no, sorry, I need to go to that screen, and then I think does that now show you the slides as they are?
Not quite yet, but I'm sure it will. So did you choose green and share?
Hang on. No. In slideshow. I thought I chose the right. Okay. So that's that one.
Yep, that's all good, Warren. We've got you now. Thank you. Perfect.
Okay, and then that should now go to.
Yeah, we've got the full screen.
And that should now show you full screen. Excellent.
Yeah. All
okay.
Good. Thank you.
So, thank you, Elizabeth. Thank you, Dimitri. As Elizabeth said, I'm a bioengineer at Imperial College at South Ken. And as I said to Amandeep, I actually worked as a bioengineer at Royal Perth Hospital for 3 years. Was one of my first jobs in bioengineering. I wasn't quite sure what Dimitri wanted me to do with this session, but so what I'm wanting to do is to explain to you a bioengineer's view of bone and fracture fixation, so that I hope you can then understand and analyze the images that you'll be looking at with our eyes as well as with your own eyes. I hope that's useful. For an engineer, bone is a very fascinating material, and a lot of this is revision for you, but I just want to point out that we are aware that there's cortical bone, there's trabecular bone, and that bone also serves multiple functions, not just mechanical, but also it's a calcium store, and it's a chemical warehouse for processes. And all of this means that bone, what goes on with bone is very complex as far as we are concerned. Now, cortical bone in itself is a very complex structure, and as an engineering material, it's fascinating how the complexity, we actually recognize complexity of bone structure on 7 different scales of magnitude. And certainly we also recognize that trabecular bone is the same material as cortical bone. It's just arranged in a different arrangement, and that, as with cortical bone, is very mechanically driven. And as I said,
Warren, can I just interrupt you for a moment, please? Would you mind turning off the video of your face just so that the sound improves?
Yes.
Many thanks.
Yes.
And then afterwards, obviously, we want to see your face again.
Right. Hang on, I'll just...
I can try to do it for you. Let me see if I can stop your video. Oh.
Yeah, that worked. Thanks, everybody. That's perfect.
Yeah, that's it.
Thank you. Okay, so then... Okay, is that better now? Is that all right?
Yes, that's better. Yes, that's better.
Okay. No problem at all. So as I say, bone is a complex material right down to the molecular structure, to the atomic structure. And in particular, the bone turnover, as you know, all bone is replaced in 3 years. And the bone turnover itself is mechanically driven. So we have these bone multicellular units, which are, and you're aware of osteoblasts laying down the bone, following osteoclasts. And we know that the bone resorption is driven by microcrack damage to the bone, so that there's a mechanical orientation to the remodeling process that is removing damaged bone, it's laying down new undamaged bone, and in doing that, the osteocytes are trapped within the bone matrix, and as it's the osteocyte processes within the canaliculi that detect fluid flow, which is the mechanical transduction mechanism that osteocytes use for sensing that the bone is being loaded or not loaded. And because of this, the remodeling aligns with the main stress direction, the main loading direction, so that we can, if we change the loading to a bone segment, the bone will realign with the remodeling process through this load moderated remodeling process. And we know that the process takes up to 6 months to occur, but that the resorption occurs in the first month, so that it's a very immediate response to bone mechanical function. So that's a thing that we are very concerned about. Now, with bone turnover, trabecular bone, that occurs on the surface of the plates and the struts, which make up the mass of the bone, whereas with cortical bone, it's all occurring within the bulk of the cortical bone. And we now understand that there is, we understand the mechanics of bone remodeling. So there is what is called this lazy zone, that during normal activity, bone turnover is really just concerned with maintaining the existing mass. If we increase the stimulus to the bone, then we can get more severe bone apposition, we can get bone densification. And the classic argument for this, or the classic discussion in this, is about professional tennis players, whom I don't know if you've seen, but their functional arm is up to 25% greater in bone mass than the non-dominant arm, the non-functional arm in their tennis game. Furthermore, we know that it's also understood that it's not just a case of needing some loading rather than no loading. This is a well accepted diagram that engineers use to understand the remodeling process. And I want you to note that fluid flow is on the vertical axis and shear strain is on the horizontal axis, and then there's also an element of time that comes into this. And the point I want to make here is that axial loading, so tension or compression, is helpful for bone densification and bone formation, whereas shear, such as you would get with sliding a material across the bone. So when you get sliding between an implant and bone, that will be applying shear to the interface. And the more shear you get, the more likely you are to get cartilage and then fibrous connective tissue. So that axial loading is helpful, shear loading is unhelpful. And these conditions, we understand. It's well documented now how much bone is how much loading is needed, and we talk about microstrain. That is the actual tissue deformation which is occurring, and so in fact it's mechanical loading that is promoting bone resorption and bone densification. Now I want to go on and just mention, as I'm sure you know also, that the fracture healing response, firstly there's the formation of a hematoma, then that is converted to a soft callus by the laying down of connective tissue across the defect, and then that soft callus is mineralized into hard callus, and then perhaps after fusion is achieved, then the bone will remodel, and of course long term you can escape with no visible sign of the fracture. We now understand very much that the processes involved in firstly forming the soft callus, and then secondly encouraging the mineralization of the soft callus to make hard callus, that these again are mechanically moderated, so that we are looking for useful, helpful mechanical stimuli in the fracture zone to ensure that good fracture healing occurs. And I do this similar lecture to my orthopedic colleagues, and I'm constantly wanting to say to them that we need to have beneficial loading for fracture healing. And so I'm sure you know that the idea of fracture fixation is to control the fragments without motion, but that's particularly without unhelpful motion, without irritation. And in fact, I would argue that we really ideally want some motion, but just in the correct directions. And we want to minimize out of plane motions, which are unhelpful. And so one of my current concerns is with external fixation, and these are very complex mechanical setups. But once again, what we are trying to do is control the mechanics of the fracture fragments. And in particular, we are really trying to control the mechanical conditions in the fracture gap. And so we're wanting to allow axial loading, axial motion, tension and compression of the fracture gap, but reduce either twisting motions, torsional motions, or transverse motions of the bone fragments. And that is true of fixation patients. And the same discussion, the same argument actually applies to post-operative healing in an implant. That I really view the implant patient as equivalent to a fracture patient. They've got a bone healing response to a newly developed bone interface. It just happens that it was a surgical insult, not a mechanical insult. Now, the reason I put this slide up is that, of course, external fixation is used in patients who are polytrauma patients, who are very complex, difficult patients anyway. So all of these can militate against good healing, and therefore it's possible that the mechanics get forgotten. And therefore, what I'm really wanting to do is to argue for using mechanics positively. It's a bit like the Team GB cycling element of the very small gains in one area. I feel that if we can improve the mechanics, then the healing will be more likely. And so again, you can see there, I'm saying that shear is bad, but axial strain is good. And if you work with people who use external fixators, I'm sure you'll find there's actually a lot more motion, a lot more interfragmentary motion goes on than the ideal stiff fixation would suggest is ideal. So what I'm trying to say is that if we view a simplified version of an external fixation patient, we've got, can you see my pointer there on the screen? Is it there visible? So there's a bone. Here's I've shown a unilateral fixator, but in fact, this is true of the cylindrical ones as well, that if this is loaded, so if we anchor the foot and load through the knee, then the bone will displace, the pins and wires will be displaced, the fixator will be displaced, again that will displace against the bone, and what is really important to us is change in the gap and is applying loading to the callus, the fracture callus. Are we encouraging healing? I've just been warned that my internet went unstable, but I think we're past that. Okay, good. Okay, so that's the stages. What we're aiming to do is to encourage an angiogenic response, which then leads to the laying down of soft callus and then leads to the mineralization of that. Okay, so that's the background to what I'm wanting to say. Now, I want to talk about Newton. Okay, does anyone know anything about Newton or anything that Newton has said? Would you like on the chat perhaps to say anything, or on the poll level? I haven't put a question down, but does anyone know anything that Newton might have said or suggested?
We'll have a look in the group chat. So everybody feel free to enter into the group chat any fact you know about Isaac Newton. We're all hiding our knowledge so far. Oh, Amandeep says multiple laws.
Yes,
yeah, that's true.
Yes, yes, and Amandeep is right in that there are at least 3, I think, Amandeep, aren't there? Does anyone know any of Newton's laws? Action and reaction. Yes, that's a good one. Excellent. Okay, I personally have come to gravity. Yeah, he recognized gravity. Okay, so one of Newton's most important findings, his first law, basically says that nothing moves unless force is applied. Yes, Amandeep, F equals ma. That's the second rule, which actually is saying that the rate of change of momentum of a body is proportional to the total force. Yes, you both get the prize. Well done. And then the third law of Newton is that to every action there is an equal and opposite reaction. Okay, so what I want to do is, so what Newton actually said, which I think is just a brilliantly blinding insight, which none of us would have found, I don't think, is that every object persists in its state of rest or uniform motion unless there is a net force on it. Now, this is a key law in orthopedics. And I would rephrase it as I did on the previous slide. Nothing moves unless there is a net force on it. Which is to say, if you want something to stay still, the net forces have to be 0. And if you want to move something, the net forces have to be non-zero. And we'll come on to this. Now, I'm going to spend some time. Does anyone know any sources of force that we might encounter if we're dealing with biomechanics, with human bodies? Gravity, yes. Gravitational forces, or body weight. Yep, body weight, yes. Excellent, good. Well, tension, so muscle forces, muscle and ligament forces. And these are very important in fracture management as well, aren't they? As I've said, they're external forces, ground reaction forces. Not to forget that this F equals ma can be used. The second law can also be used in that if something is accelerated, as you know, if you've sat your drink on the table in the train, when the train starts to go round a curve, and your drink will start to move across the table, so that quite significant forces can be developed by accelerations. We also, in biomechanics, we can have external forces, and in rehabilitation that's useful, internal forces, muscles and ligaments. And I want to come back to talk about friction, but I would suggest that in fracture management, friction is a very important force to consider. And a great deal of fracture fixation is relying on friction. And then, of course, there is also the source of force. Gravitational force is weight, and weight is the mass times the acceleration due to gravity. And of course, on the moon, our weight is much less. So it's mass, which is a constant property, times the acceleration of gravity. So I want to now pose, I want to illustrate this to you by posing a problem. If we've got Dimitri's car sat on a frozen lake, I want you to consider how we might consider this. If you've got paper and pencil, you might like to take out a piece of paper and a pencil and draw a diagram of how it is good car recognition, everyone. So as an engineer, we would represent this as a block. And this is what we in biomechanics, what we in engineering call a free body diagram. And I think the free body diagram is one of my key take-home messages here. So I've drawn Dimitri's car as a block, and I've drawn the ice underneath it as a fault line. Now, does anyone know what forces might be acting here at this point? Gravity. Dimitri knows that gravity. So we would represent gravity by a downward force. And in fact, gravity acts through the center of mass. So we've got a downward force. Now, someone says there's a ground action force. So that's Newton's third law. Yes, Chong, also, there is also an upward force, and that is the ground reaction force. And that's Newton's third law, said that to every action, there is an equal and opposite reaction. And that says that the ice is pushing up at Dimitri's car with the same force that the car is pushing down on the ice. So this upward force is a ground reaction force. And if for any reason that force is not sufficient, then the ice will break and the car will fall into the lake. Now, let's stay with Dimitri's car. Let's say it's broken down and now is refusing to start. So you want to be helpful and help him push his car off the lake. So now we're looking down on the car. And again, I'm now drawing a free body diagram of the car. So the oblong is a simple representation of what's going on here. And I've drawn a person pushing. And if two of you wanted to help, you obviously would recognize that if you push from opposite ends, then you're not going to get anywhere, that you need to be pushing from the same direction so that your forces are combined. And this is the other important engineering concept, is that we can represent a range of forces by one resultant force that is the sum of those forces altogether. So if two of you are pushing side by side against the car, then you'll generate double the force that you would generate if you were pushing on your own. If you push both on the same corner but in different directions, then you will push at cross purposes, and the resultant force will be a mathematical sum of those individual forces. And notice that you could also end up, and this is where being on ice is really useful, you could end up pushing against one another but not in direct alignment, and then your forces, and I'm sure you can imagine this, your forces would not only not move it, but they would actually start to rotate it. And we call the magnitude of this rotatory force a couple or a moment. It's a turning force, and the magnitude of the couple is equal to the magnitude of the force times the perpendicular distance between the lines of action of those things. Now, the one other thing that I want to point out with this, finally, with this free body diagram, we've touched on this already, is that if we now view Dimitri's car from side on, and if we've got you pushing against the car, we can draw the free body diagram of the car as the downward force of the weight, and that's mg. The upward reactions are now going through the four wheels. So those are the ground reaction forces, and we'll call those normal reactions. And then where you are pushing against the car is an externally applied force against the car. So that's a force. Now, in this situation, what does anyone think is going to happen to the car? It's going to move forwards, says Amandeep. Yes. And Elizabeth says it will move forwards. Now, that's assuming that there's no friction. If Dimitri's left the brakes on, for example, and there's friction, then there will be a balancing force, a reaction force, which will act backwards against that. And friction is a reaction. It's a real force, but it occurs in reaction to applied forces. And you might see from this diagram that actually the applied force at the top and the friction at where the car meets the ice, that they're actually a couple. So there is an implied turning moment. Now, all of that is viewing the car as my free body. And as an engineer, we can choose which is our free body. And one of the other thing that we could do is that we could choose the pusher, you the person, as the free body instead. And then we've got we've got the downward force, there it is, we've got the downward force of gravity, we've got the ground reaction force upwards, and so the person will not fall through the ice either. And then because they are pushing against the car will push back. And that's Newton's third law again. And then what that's saying is that if we have this same situation, I don't know if you've tried this, I've actually tried it myself on snow and on ice, that if that's the situation as it is now and there's no friction, then you won't move the car forwards, you will push yourself back. And that's Newton's third law. So we need a friction force to combine. Now I'm going to jump through. What this was implying then was that we can represent a series or a combination of forces by a resultant force. And the lovely thing about mechanics is that it's all very logical and very straightforward, and we can actually do scaled drawing to show the forces, and the resultant is the sum of those two. And this, you might recognize this diagram. This is actually the forces on the patella during a knee squat, and it's showing that there is a resultant force pushing the patella against the front face of the femur. And that's the resultant force. There it is, and that's showing the same thing. And then if we've got many forces, then we can represent them by adding them all together in a string, and that will show us the resultant force. But we can also find that if, as you see, all of these forces here are not necessarily collinear, then there will also be a turning moment applied to the body, so that we can represent the resultant forces as an axial force, a linear force, and a tendency to turn. And that's another thing that I want you to bear in mind when you're viewing bone fragments or body segments, is that the forces can be linear and cause linear motion, but they could also be causing rotation. And conversely, if the orthopedic surgeon is wanting to cause rotatory motion, then they will need to apply a turning force. Applying a linear force is just going to cause linear action. Now, the example that we use for all of this is when we consider single leg stance, that we know that there are the abductor forces, and actually the muscle forces are complex. There are many muscles at action. Then we can represent them quite simply by one resultant force for the abductors, one resultant hip joint contact force, and then the ground reaction force through the foot. And in this diagram, can you see we're choosing the femur as our free body, and it's very common to confuse the which body you are working with. Are you considering the pelvis, or are you considering the femur? And I want you to bear that in mind, that it's important to make up your mind. What is your free body? Are you considering the femur, or are you considering the pelvis? Now, when we consider the single leg stance effect on the pelvis, then we've got the same abductor force, but it's in the opposite direction. We've got the same joint contact force, but it's in the opposite direction. And now, instead of a ground reaction force through the foot, we've got body weight acting through the center of the pelvis. So all of that was background, sorry, to lead me to this, that when you start to see images of fixation devices and of bone segments, then what I would like you to do is to recognize what is the free floating bone segment here, and to view that as your free body diagram. And it's important at that point to recognize and take account of all sources of force which may be causing things to happen. Now, this is, as you'll be aware, this is a dynamic hip screw, and one of the corollaries of our rule about being able to represent a group of forces by one single resultant force is that we can also resolve one single force into 2 or 3 components. And this can be very helpful in understanding the mechanics of a fracture fixation or a fracture management situation. So, for example, with a dynamic hip screw, where we know that the body force is probably angulated to the axis of the screw, we can resolve this force into 2 orthogonal components, one of which is parallel with the screw and one of which is perpendicular to the screw. And the parallel force is going to be the force which is going to cause telescoping of the fragment, of the fracture surfaces, and the perpendicular component is going to be the one which is going to give rise to friction in the device, but also, as I said, it's going to be resisted hopefully by friction in the fracture surfaces. So then the next case I wanted to demonstrate in regard to that was this rather nasty oblique tibial fracture. And you can see the fracture plane is there at an angle, so that if we consider the forces which are occurring here, then obviously the knee is going to apply body weight down through axially through the tibia, and that's going to be at an angle to the plane, but we can resolve that into its 2 orthogonal components, and therefore we can state that the perpendicular component here is going to give rise to friction. It's going to encourage or cause friction between the bone surfaces, whereas the parallel component is what is going to be causing the fracture fragments to glide past each other. So when we consider the different types of proximal femoral fracture, for example, then it becomes important again to resolve the forces on the fracture plane, perpendicular to the fracture plane and also parallel to the fracture plane, as in this case. And this, I think, explains why some proximal femoral fractures are stable and some proximal femoral fractures are unstable. And it's about this balance between the normal, the perpendicular component of force and the force which is going to cause the bone fragments to slide past each other. And I hope that in viewing X-rays in that way, in viewing plane views of fracture fragments and devices, then you will see, you can quickly understand whether the system is stable or unstable. And I want to remind you that, yes, this point that if something is moving, then there is a net force applied. Or conversely, if we want something to be stable, we've got to ensure that the net force is 0. And engineers use the reverse logic of that, in that if something is not moving, we know that it's in equilibrium, that the net forces are 0. Now, the really good news about that is that if something is in equilibrium, the net forces are 0 in every direction. And we can consider them in any direction and see that the net forces are still going to be 0. So for example, with this kind of proximal femoral fracture, if the surgeon is wanting to reduce this fracture, what forces do you think are going to be acting on this proximal femoral free body when they try to reduce the fracture? Axial loading and shear, yes. Are there any sources of force that the surgeon needs to be aware of in trying to reduce this fracture?
So, and what about the muscle attachments that might also kind of pull?
Yep, absolutely. It's the abductors, and that's very much a hidden factor in the equation for the surgeon, is neutralizing or overcoming the muscle attachments, and that also in fracture management. Now, I mentioned about turning moments, and one of the classic illustrations of turning moments is when we are looking at the forces about the elbow. So this is a simplified engineer's diagram of so this is the humerus, this is the upper arm, and this is the radius and ulna here at an angle at the elbow. And if we hang a weight off the hand, then what we're saying is that the moment due to that force, due to that weight, is the magnitude of the force times the perpendicular distance between the force and the elbow. And the point of saying that is that as the elbow flexes or extends, then the force, the moment applied to the elbow is going to increase at the point when the forearm is at 90 degrees to the humerus, and then it's going to decrease as the elbow gets more flexed or gets more extended. And this is representing moments. Now, I can skip this because I've talked about friction already. I just wanted to again say that we could use a book on a table as a free body diagram. And when we push on the book, then it will move unless the balancing friction is not overcome by our force. And I've said that about equilibrium. So then coming back to this question of recognizing, are bone segments going to be stable? Are they going to move, or are they going to be maintained? Then we can view them as free body diagrams. We can recognize all the sources of force. And for example, in a segmental fracture like either of these, then we recognize that this segmental fracture is going to move unless the sum forces on the segmental fracture are neutralized, unless there's zero force. And so and that, I think, in particular, the point about neutralizing forces, as I said, forces can be axial or they can be rotational. And with a segmental fracture like this, there is a real risk that we can deal with the axial forces or the transverse forces, but not recognize the rotational force. And that, again, if you're viewing a case like this, or like that, then we want to be able to say, oh, sorry, it's there. We want to be able to say that the axial forces are controlled and the rotational forces are controlled, that this segmental fracture is truly in equilibrium, that there is zero displacing force. Now, as I said at the start, in fact, what we really want is we want some beneficial axial force to generate fracture healing, and we want to minimize rotational torque, rotational motion, or transverse motion, which would cause shear and which would then lead to a fibrous non-union, not to healing. So I've got I've got a few more cases, but I think I'm going to stop there because that was what I was trying to make the point about, was when we consider whether a fracture fragment is stable or non-stable, it also depends on the frame of reference that we are using. So to go back to this proximal tibial fracture, I can represent that in a free body diagram with a body for the proximal tibia and then a body for the shaft. And from the frame of reference of the knee, the shaft of the tibia is going to be being pushed upwards and to the right. I can't remember if it's laterally or medially. Whereas from the tibial frame of reference, then the proximal fragment is going to tend to be pushed downwards and to the left. And so the surgeon will apply a buttress plate, and that actually is withstanding this component of the force, which is tending to slide the proximal fragment down the fracture face. The same can be said when we come to proximal femoral fractures, and that's why there's great debate in orthopedics about whether an intramedullary device or an external plate and hip screw and so on is advantageous. The disadvantage with the external fixate, so the intramedullary device has a mechanical advantage because the moment arm of the body weight is reduced. The perpendicular distance between the body weight, the line of action, and the line of action of the intramedullary device is reduced compared with a lateral plate and a dynamic hip screw or such. I've lost one. But that can then tend to cause the plate to be pushed off the external face of the lateral face of the femur. Whereas with an intramedullary device, it's maintained within the fracture. I hope that helps you understand the mechanics of understanding fracture fixation. I hope that gives you an insight into dealing with that. I'm going to stop there. That's the reference for the mechanical stimulation for bone resorption that I borrowed there. But
thank you so much, Warren. That was fantastic. Certainly for me, and I think anyone else who hasn't had been an orthopedic surgeon in a previous life, I've never actually really thought about things in those terms. And I have to say the physics was really exciting. Sound like the ultimate nerd, but it was really exciting. Thank you very much.
Right. Thank you. Okay.
Oh, we're getting lots of nice feedback for you. So just, I realize it's 2 o'clock and everyone's probably got to rush off to their afternoon lists. Just to remind you, we've sent the link for feedback. If you give us feedback, we will send you handout notes, and we will also send you an attendance certificate with CPD points. We hope to see you all next week on Tuesday, the 15th of September, when we've got the King's College team presenting, Dr. Bhavna Batohi and Dr. David Elias, talking about fractures and fracture non-union. So thank you everyone so much for contributing to this first session. And thank you especially to our 2 speakers. It's been fantastic.